very good morning to all of you present here. And I welcome you all to the morning session on the precision approach to managing severe VKCs, taming the old foe. And we have got a series of speakers, experts and stalwarts in the field of management of VKC. And we have got, we would be starting the session with Dr. Mamta Singh. She's additional professor at AIMS Rajkot, and she would be speaking on the diagnosis and severity classification in VKC. Then we have Professor Radhika Tandon, Chief of RPC and heading the cornea unit. She would be speaking on pharmacological management of VKC. Next, I would be speaking on surgical management of VKC. We have Dr. Sunita Chaurasia speaking on the complex overlap of VKC and KC, and Madam Sujata Das, she'll be speaking on managing limbal stem cell deficiency in VKC. And towards the last, we would have Dr. Nikhil Gokhale sir, who would be speaking on severe VKC, a case-based discussion on a compilation of all the management strategies and his approach and his experience in managing severe VKCs. So we all are aware that VKC is a very frequently encountered disease condition, and it involves, because it's a chronic and a chronic disease entity, it involves multiple follow-ups, multiple therapeutic approaches. So this instruction course has been precisely designed to offer the approach to diagnosis, to management, both medical and surgical, in an optimal way to secure an optimal ocular surface. And without much ado, I would start the course, and I would invite all my co-instructors to please take the seat on dais, please. Ma'am Sujata, Dr. Gokhale, and Dr. Mamta Singh, please. Yes. So we start with the first talk of the session, Dr. Mamta Singh. Yes.
Very good morning, all of you. And I'm going to start with the diagnosis and severity classification of vernal keratoconjunctivitis. I'm really thankful to Bhavna ma'am for this wonderful opportunity. This is going to be more of a basic talk. Whenever we get a case of diffuse conjunctival congestion, we need to ask certain basic question if we are trying to diagnose allergic conjunctivitis here. Is this truly a case of allergic conjunctivitis? And if it is, what type of allergic conjunctivitis it is? And as we are paying attention here more on vernal keratoconjunctivitis, is this truly a case of vernal keratoconjunctivitis? And if it is, what or how severe it is? So coming to the first question, is this allergic conjunctivitis? Whenever we get a case of diffuse conjunctival congestion in our clinical practice, we need to think of some of the basic problems first, like infective conjunctivitis, dry eye, episcleritis, allergic conjunctivitis. So infective conjunctivitis, they usually occur in crop. Multiple people get affected at the same time. If you are talking about viral conjunctivitis, then serous discharge, chemosis, subconjunctival hemorrhages are some of the clinical signs. Then bacterial, we all know it's more of purulent discharge. Dry eye, on the other hand, there are certain clinical signs and clinical tests over the ocular surface that one can perform to clinch the diagnosis. Episcleritis is more about heaviness and pain, and the level of congestion here would be different. It would be more of episcleral vessel. That is something where we need to pay attention to. And on the other hand, allergic conjunctivitis is more about itching, and how the signs and symptoms differ, we'll see in subsequent slides. So what type of allergic conjunctivitis it is, and is this vernal keratoconjunctivitis? Allergic conjunctivitis can be simple, atopic, or vernal. Simple allergic conjunctivitis is the most common form of ocular allergy. There is no corneal involvement in these cases. There are two variants, seasonal and perennial. Seasonal is more because of airborne pollens. Signs and symptoms, they are more prominent in spring and summer and generally abate during the winter months. Perennial, on the other hand, is due to exposure to the perennial allergens. Atopic allergic conjunctivitis is seen mostly in adults. It is perennial in nature. It is considered as the ocular counterpart of the atopic dermatitis. Association is seen with asthma, dermatitis, rhinitis, hay fever, etc. Eyelid skin here gets affected. We can see ecchymosis or fine sandpaper-like texture. Here one can get the conjunctival and corneal involvement both. I think this is the older slide they are playing. Okay, let's continue. VKC, on the other hand, is bilateral recurrent allergic inflammation of the conjunctiva. One gets the persistent progressive course punctuated by episodes of acute exacerbations. And if the disease remains uncontrolled, it causes non-reversible damage to the ocular surface, leading to poor quality of life. There is the seasonal or perennial type. VKC is disease of warm climates and warmer months, and that is the reason seen more in tropics than in northern climate. Younger children are affected more with remission by the late teens. If we talk about VKC in adults, then it can be a disease, a persistent disease started during the early childhood or can have its onset, but that is less common, its onset after puberty. One of the studies from India, they have reported 10.4% having people having adult onset VKC. Till the age of 20 years, male are affected more than female, but beyond that, both the genders are equally affected due to high androstenedione level of androstenedione level in postpubertal girls. This disease is characterized by intense itching, hyperemia, tearing, photophobia, and ropey mucus discharge, and the intensity of these symptoms are particularly distressing in the morning, also known as morning misery. The symptoms are exacerbated by exposure to non-specific stimuli like wind, dust, bright light, hot weather, etc. Sticky mucous filament, also known as ropey discharge, is characteristic of VKC, and it is mainly due to chronic ocular surface inflammation leading to excessive mucus production. It contains inflammatory cells, especially eosinophil, Charcot-Leyden crystals, mucopolysaccharides, and hyaluronic acid. The signs can be divided into conjunctival signs and corneal signs. Conjunctival signs, the earliest is generalized conjunctival hyperemia. It has got three distinct forms: palpebral, limbal, and mixed. Palpebral form, the lids get affected. Majority of these patients, they have slightly sleepy appearance because of partial ptosis. This can be due to constant rubbing or because of the mechanical ptotic effect of papillae. The most characteristic sign is the giant papillae on upper tarsal conjunctiva, also known as cobblestone papillae. They can be several millimeters in diameter. They can be discrete or they can be clumped together. Histopathology of these papillae, they show intense collagen proliferation with cellular accumulation like polymorphoneutrophils, plasma cells, mast cells, and eosinophils. And the papillae size correlate with the worsening of the symptom. In addition, one can get punctate staining of this papillae in active form of the disease, but they persist even during the inactive phase of the disease. Accumulation of mucoid fibrous discharge in the form of a pseudomembrane over this papillae is known as Maxwell-Lyon sign. Limbal or bulbar form. Here we get discrete limbal nodule. They can be seen nasally temporally, or they can be seen running around the entire limbus, making a ring of raised gelatinous hypertrophic tissue. Horner-Trantas spot, they are chalky white spot seen over this limbal nodule. They are clumps of necrotic materials from eosinophil, neutrophils, and epithelial cells, and they are suggestive of active disease. In Asian population, fine golden brown pigments are seen in the perilimbal area, and they suggest chronicity of disease. They have nothing to do with the activity or active stage of the disease. Punctate epithelial keratitis, also known as keratitis epithelialis vernalis of L-Topgi. Next is shield ulcer. These are oval-shaped epithelial defects seen on upper half of the cornea. They are either due to coalescence of punctate epithelial keratitis or due to mechanical frictional effect of tarsal papillae over the loosened corneal epithelium due to inflammatory mediators. If they remain untreated, a plaque is formed over them, leading to their impaired healing. Cameron has divided these ulcers into three grades. Grade 1, where we have a transparent ulcer base. Usually they respond to the medical treatment. Grade 2 is what we are seeing here in this picture. They have translucent base with or without opaque white-yellow deposit. If they are not responding to medical treatment, in these cases, debridement or AMG may be required. Grade 3, where we get elevated plaque formation, often refractory to medication, requiring debridement and AMG for treatment. Pseudogerontoxin, it resembles Arcus senali, and there are waxing and waning grayish-white lipid deposition over the superficial stroma of the peripheral cornea. VKC in Indian scenario is predominantly a mixed form of disease. More than 1/3 of the patient, they have chronic perennial form, and there is lesser association with atopy and systemic allergy as compared to patient in the temperate zones. So next question is how severe it is. An ideal severity marker would be some sort of biological marker or some sort of serum marker which can measure directly in laboratory, but that is not possible in VKC. The reason being, even if we do some sort of allergic test for these patients and if the person is coming positive for this test, not necessarily that VKC will also respond to the same allergen. They are more towards the non-specific stimuli, and that is the reason we are dependent on clinical grading system. We have two important clinical grading systems that I'm going to talk about today. The Bonini grading system proposed in the year 2007. It divides the disease into 5 categories from grade 0 to grade 5. Both grade 0 and grade 5 are mostly asymptomatic, but in grade 5 we'll get to see the mild to severe fibrosis or some sort of evidence of tissue healing. Otherwise, between these two, it divides the disease into mild, intermittent, moderate, persistent. But it doesn't really say or doesn't really describe when do we call something a persistent disease or when do we call something intermittent disease. And then followed by severe and very severe. Presence of corneal ulcer divides or makes the disease very severe, and presence of Horner-Stanta spot makes the disease severe. So next we have the Gokhale grading system proposed by Dr. Nikhil Gokhale, and it very clearly says when do we have this intermittent disease and when do we have this chronic disease. Intermittent when the inflammation-free interval or patient is off medication for more than 2 to 3 months, and there is maximum of 3 to 4 episodes in a year which remit on therapy. While chronic when the inflammation-free interval is of less than 1 month, during which the patient is off medication, and there is this continuous ongoing inflammation which possibly recurs on attempting to either stop the therapy or taper the therapy. It divides the disease into mild, moderate, severe, and very severe. Moderate is again divided into moderate, intermittent, and moderate chronic depending on the persistence of disease. We need to pay attention to the bulbar conjunctiva, tarsal conjunctiva, cornea, and limbus. If there is no cornea and limbus involvement, the disease is mild. Moderate, as I said, can be moderate, intermittent, and chronic. Moderate, intermittent when there is less than 1/2 of the limbus is involved or the limbal inflammation is less than 6 o'clock hour. Moderate, chronic when they have the presence of cobblestone papilla which continuously makes the patient symptomatic. Severe when more than 6 o'clock hour of involvement is there. And in blinding disease, we get the chronic sequelae of this disease like LSCD, conjunctivalization, tarsal scarring, etc. Here in this picture, one can see the loss of limbal stem cells as well as corneal scarring. Some sort of vascularity has also been developed. In next picture, one can see less than 6 o'clock hour of limbal involvement here. In addition to the clinical grading system, we also need to pay attention to the complication which can be disease-related or they can be treatment-related. Disease-related complications like corneal scar, LSCD, keratoconus, etc. or treatment-related like cataract and glaucoma, which can be steroid-induced. So if I have to conclude, I would say not every red eye allergic conjunctivitis and not every allergic conjunctivitis is VKC. VKC is essentially a clinical diagnosis and we need to pay attention to the clinical grading system. The reason being there are multiple disease and treatment-related complications. Thank you.
Thanks, Dr. Singh. Since Professor Tandon is not here, we will take the next talk by Professor Bhavna Sharma. She is Chief Instructor of the course and she is a Professor of Ophthalmology in AIMS Bhopal. So we'll take the questions at the end of the...
We have a small change in sequence. I invite Dr. Sujata Das. She's heading the Cornea Center at LV Prasad, Bhubaneswar, and she would be speaking on managing limbal stem cell deficiency in VKC challenges and strategies.
Okay, good morning. Thanks, Professor Sharma, for including me. Like last few slides, Dr. Singh has described that 1.2% of VKC has LSCD. It may be partial, it may be total, but around 1.2% has LSCD. So VKC, as all of us know, it is a bilateral allergic disease and affects children and young adult. But the LSCD, if you see the age between LSCD and no LSCD, usually LSCD patients are older than, because since it takes long time for LSCD, they're usually older and the duration of symptom is more compared to those who do not have LSCD. So why limbal stem cell deficiency occurs in VKC? Because of the chronic inflammation damages limbal stem cells and eosinophil-derived cytotoxic mediator, mechanical trauma from giant papillae, and recurrent epithelial breakdown. So failure of corneal epithelial renewal, conjunctival epithelial ingrowth, goblet cells on the cornea, and vasculation and scarring. Most of the patients present as like VKC. There's no specific which where you can, it is mostly diagnosis is clinical. They present with redness, photophobia, pain, watering, foreign body sensation, and progressive visual decline. All these are symptoms of VKC, not necessarily due to LSCD. Or the corneal findings specifically for LSCD is superficial vascularization, Parnas formation, epithelial irregularity, stromal scarring, and loss of palisade of boat, and limbal thickening and scarring. So these are some cases where you can see, So these are partial LSCD, and this same patient has bilateral. It may be asymmetrical sometimes. And this is a patient again active VKC with partial LSCD. The vision is 2250 in right eye, 2160 in the left eye. You can see apotraceal conjunctiva, but sometimes the LSCD may be active VKC or it may be inactive, no papillae, vision not symptomatic. The stippled appearance of cornea. And after 1 year, the same patient, although you can see the visual, I don't know how it changed because the visual is better, but if clinical finding is worse compared to last 1 year back. So now it has almost become total, and this has progressed to near pupillary area. So how do you confirm this goblet cell on the corneal surface? Although the diagnosis is clinical, but to confirm, you can do a histoimpression cytology, squamous metaplasia and chronic inflammation. These are some of the pictures of conjunctiva and corneal surface. This is a normal corneal epithelium. You can see the epithelium has become big and goblet cells on the cornea. So as I already mentioned, mostly the diagnosis is made clinically. If you are in doubt, maybe impression cytology, and if you have access to confocal microscopy, you can take help of confocal microscopy. ASOCT helps in decision making in therapeutic approaches as well as for diagnosis. If you are planning for Parnas dissection, whether you will do it combined with talc or only slate will help, ASOCT can. So this basically the challenges of LSCD related to VKC. These are specific challenges because the inflammation continues, and this is bilateral disease, unlike LSCD due to chemical injury that may be unilateral. Here 99% will be bilateral, and pediatric population because you need immunosuppressive in some cases if you are doing surgical, recurrent episode, and steroid dependence, poor compliance, and risk of infection. And LSCD, how does it, in case you may not, all of them may not need any treatment. Some of them may just, if it is a vision is normal, vision is irregular. So impact on vision due to corneal opacity, irregular astigmatism, and VKC we know associated with keratoconus. And principle of management in specific to VKC, you need to control the inflammation, stabilize ocular surface, restore stem cell and visual rehabilitation. So if you are doing in active inflammation, there is always a risk that stem cell make pale and increases the risk of surgical indication is indicated where it is advanced or total LSCD, especially if the visual excess is involved. If the visual excess is not involved, you may not do surgery, and there is a persistent epithelial defect, which is a criteria to diagnose LSCD, and failure of medical therapy. So chronic VKC can progressively destruct limbal stem cell. It can resolve conjunctivalization, vascularization, epithelial instability, advanced disease which is refractory to medical therapy, and restoration of stem cell population is essential. So BKCIs are better in term of slate compared to, I'll say, other LSCD because of the weight ocular surface and minimal cicatricial adnexal disease. Minimal means there is nothing, nil actually, and often that stroma is unaffected, and young patient has high visual potential. So limbal stem cell is preferred in advanced cases. This is the published case report. You can see the right eye has completely total LSCD. Absolutely, you can't see pupil. And in this case, like I mentioned, OCT helps. You know the OCT, this is a hypertrophied epithelium. If you remove, maybe the stroma will be clear. So this is the picture, same picture with when during slate and on the intra-op, and you can see the right eye, which is absolutely looks like a normal. Unless you know the history, it looks like most of the time it looks normal. So what are the options for limbal stem cell? It may be autologous, but BKC, as we know, it's most of the time it is not applicable. Either we do a allogenic LSCT or CLET, slate, or KLL. So disadvantage is allogenic, you need a immunosuppression. CLAT, as we know, it requires slab. Almost it is stopped after SLAT. We're not doing CLAT because it's high cost and we need regulatory issues, and it is a single stage procedure, allow SLAT, and when you do CLAT, it takes double sitting when need live related persons and do the culture. So better is allow SLAT over CLAT. And reported survival is very good, is 90% in 5-year survival. And risk of rejection, of course, is there, but compared to conventional graft, it is less. And most commonly used immunosuppression is cyclosporin A. Other agents are mycophenolate, tacrolimus, and systemic corticosteroid. So additional benefit is VKC is itself immune mediated, so you get advantage of both. So VKC is controlled as well as SLAT is taken care, and it reduces inflammatory exacerbation, may prevent progression of LSD in fellow eye. If you are doing in one eye, so it will take care of other eye. Another option is scleral contact lens, which is very useful nowadays. You can try if it is not a full, if it is now surgical not required, or sometime after surgery also it can help. But however, proper pitting is essential. Poorly pitted lens may lead to again limbal compression, damaged stem cells. So expert is required to pit contact lens, scleral contact lens, although the cost is quite high. And with correct pitting, you can have good vision, ocular surface stability is maintained, and does not adversely affect transplanted limbal stem. It's multimodal approach. You can do combined with yellow SLAT plus scleral contact lens. The step 1, you go stepwise, control VKC inflammation, then restore stem cell with SLAT, then visual rehabilitation with scleral lens. So either scleral lens or approach. Keratoplasty is at the end in case it is not taken care by all these modalities, and very rarely keratoprosthesis may be required. So post-operative care, you need to long-term allergy control, lubrication, immunosuppression, and monitor for the recurrence. Usually the outcome is good in SLAT or scleral contact lens if it is not a total. Scleral contact lens did not impair limbal transplant because it looks like it is affected limbal transplant, but it's not because there is a fluid in between. So to conclude, it is a severe complication of VKC. If it is 1.2%, I'll say maybe out of those, less than 30% will require any treatment. However, early recognition is critical. Control inflammation before surgery and multimodal management gives best outcome. Thank you.
Thank you for the wonderful talk, ma'am. Can I have a quick question here? Yes. Ma'am, if you are managing a case of limbal stem cell deficiency due to some other cause, and if you have a VKC, so your approach differ in some way or it remains the same?
So you mean VKC with some other?
No, it's only plain VKC versus limbal stem cell deficiency due to some other causes if you have.
Yeah, like I mentioned, it's a good candidate for limbal stem cell transplant. Otherwise, difference is it's a recurrent disease. Chemical injury, maybe one go, it is done. Either you do SLAT, then treat, it is fine. But VKC, you have to give continuous treatment about the allergy part also.
And do you go for anything systemic in those cases, systemic medication in?
Only VKC without LSD or?
With LSD after SLAT, I'm asking.
Yes.
Okay.
If it is allo SLAT, you have to give cyclosporine for longer period.
Long time. Thank you so much, ma'am. Okay. So next we have Dr. Professor Bhavna Sharma ma'am for her talk, and she's going to talk about when drugs are not enough, what are the surgical options we have for refractory VKC. Over to you, ma'am.
Yes. So very good morning to all of you. And preceding this lecture, actually, we had medical management of VKC by Professor Radhika Tandon. I'll skip this. I'll be preceding her because she'll be preparing her. She's loading her lecture in the meantime. So, from the conservative management, when the VKC is severe or where there's a structural deformities, we need to go for surgical management. And these are the indications for surgical intervention. That is, when there's a failure of medical therapy, There are vision-threatening complications, and of course, when there are severe structural changes. So these are the structural changes or the structural damage which has occurred, which requires surgical management. That is the GPCs, neovascularization. There may be scarring because of Shields ulcer, corneal ulcerations. There may be limbal stem cell deficiency and visual impairment, which would require surgical intervention for salvaging visual acuity. And these are the complications which require surgical intervention: the GPCs, Shields ulcer, formation of corneal plaques, limbal stem cell deficiency, corneal opacity, keratoconus, and the sequelae, that is the cataract and steroid-induced glaucomas, SPEs sometimes. And the surgical modalities which one can have while managing VKC are the supratarsal injections, surgical excision of papillae with MMG, superficial keratectomy, PTKs, amniotic membrane transplantation, LS limbal stem cell transplantation, and corneal transplantation. I would take them one by one subsequently in the lecture. So the preoperative considerations are as important as the surgical intervention here. So the surgical intervention should always be done in these cases when the ocular surface is stabilized and the VKC is optimized and the eye is quiet. So with that, this can be achieved by appropriate medical management with the help of antihistamine, steroids, or immunomodulators. Any subclinical infection like MGDs or subclinical HSV, IOP control should be first managed. The choice of anesthesia is largely depending on the age. If the patient is cooperative, you can take the patient on a local anesthesia, or most of the time when they're children, you would want to take the patient under GA. It is also important that because this is a disease of chronicity and recurrence, so adjuvant therapy is given post-operative also. So prevent recurrences, you would want to give MMC or post-operative steroid. I think that would be covered in the section of medical management. Now, counseling is also as important as the intervention, where you would counsel the patient that, look, we have done the surgical intervention, but that may not be sufficing because the disease is chronic and you would require any other procedure, and you would want to continue with the medical management. So we would take one by one the surgical interventions. First, we would take the injection, that is the supratarsal steroid injection, which is required in cases of GPCs when there's mechanical damage by GPC and causing corneal erosions or Shields ulcer. Of course, the rider here is that some of the patients would be steroid responders. So we should carefully monitor these patients for any rise in IOP and for further management. So the indication is when there's severe refractory GPC, there's giant GPCs, there's mechanical erosion. What to inject? We can inject triamcinolone in the dose of around 20 milligram per point or 0.5 ml. Dexamethasone, that is around 2 milligram, that is 0.5 ml. And it is injected 1 centimeter above the superior tarsal border. And this is how you want to give the video is not running. Excuse me, the video is not working. Now it's. No, I have to take the cursor there. The previous one. Can you put the screen side? So this is how you would want to give the injection. You avert the lid, put the topical anesthesia, avert the lid, and once you have identified the GPCs, you just want to inject with a 26 gauge or a 27 gauge needle, 1 millimeter above the superior tarsal border, making sure that you do not balloon the conjunctiva. It is over at just above the molars, just over the tarsal plate, and not to put the excess injection also, otherwise it may result in corneal necrosis, conjunctival necrosis at a later date. Okay, so there's one other injection. You can see that it is being given in the superior tarsal plate, in the supratarsal area, and so that was about the supratarsal injection. The next procedure is the surgical excision of papillae. It has been demonstrated in one of the previous instruction course also. So when the GPCs are causing corneal erosions or the mechanical damage to the cornea, particularly in the superior part, and there is formation of Shields ulcer, one would want to do the excision of these GPCs with the help of the Westcott scissors, and you can just avert the lid as was shown in the previous slide with the help of topical anesthesia. You can infiltrate the anesthesia also over at that side, and then you can do the excision of these papillae with the help of Westcott scissors. Sometimes you can do a simple shaving with the 15-number blade here, and it can be supplemented with either an MMC 0.02% to prevent recurrences, or you can resurface it with an amniotic membrane graft. So it prevents erosions, corneal erosions. It promotes healing, epithelialization, and of course the healing of the Shields ulcer if it is present. There may be chances of recurrence, so as I said earlier, you would want to supplement it with a adjuvant therapy, maybe post-op steroid or MMC, to prevent recurrences of these papillae. The third procedure is the mucous membrane grafting. Now the mucous membrane grafting is done again in when you have done the excision of the GPC to cover the smoothen that surface, and the indication is you would want to prevent keratopathy, any erosions of the ocular surface which is occurring. It is not to be done as a prophylactic measure. Only when the keratopathy is present, one would want to do an MMG. It relieves ocular irritation. It is preventing progressive keratopathy, and of course for the visual rehabilitation in these patients. So the procedure or the surgical technique is that we can harvest the mucous membrane from the buccal mucosa. We can harvest the mucous membrane from the buccal mucosa. The size is appropriate as per the lesion which you have identified, and the cleaning is important. You clean all the buccal fat from that. You can identify that the cleaning is complete once you can see the once you can see the marking on the undersurface, and after the excision you can suture with the mucous membrane graft onto the excised papillae with the help of these interlocking sutures. One would want to argue that there may be recurrence of papillae underlying these mucous membranes, so we would not be able to identify because that is hiding or masking that papillae. So you want to continue in the post-operative period with the steroids or MMC so that the recurrences can be mitigated. The next procedure is the superficial keratectomy. We can do superficial keratectomy in cases where there's formation of plaque over the corneal surface, mostly in cases of Shields ulcer, and where there's erosions over the surface, you just want to smooth, we want to do a keratectomy with amniotic membrane transplantation. So this is the procedure which can be, this is how it is done. You do the erosion with, you do the removal of these plaque with a simple hockey stick or with a 15-number blade or a crescent knife we can do, with gentle freshening of the margin of the ulcer or the freshening of the margin of the epi defect over that, and followed by the application of amniotic membrane. Then is the PTK. One can do PTK with the help of excimer phototherapeutic keratectomy, again in cases of small opacities, in small erosions which are in small opacities, and fibrinous plaques, where you can just remove the superficial opacification to make the underlying surface more transparent and for visual rehabilitation. Then we have got the amniotic membrane transplantation. So amniotic membrane transplantation in surgical management of VKC is generally employed for cases where there's Shields ulcer, where there's ocular surface inflammation and erosion. So here you would want to do first the epithelial debridement, removal of the surface plaque, removal of all the exudates over the surface with gentle removal with a hockey stick or a crescent knife, and followed by application of the amniotic membrane. You can put a circumferential suture with a 10-0 nylon, and then in this manner the amniotic membrane is adhered. One can put a fibrin glue over the surface. An application of suture is important in pediatric cases because the children can dislodge the amniotic membrane by rubbing the eyes. So an application of the contact lens, the bandage contact lens. One can also employ the interrupted interrupted conjunctival suturing, like in this case, after application of the amniotic membrane on the corneal surface and with the help of fibrin glue, you would just want to reinforce this placement of the amniotic membrane with the help of sutures. The side is important, the stromal side down and the epi up is important. It should be adequately sized, otherwise the children while rubbing can just dislodge the amniotic membrane. The limbal stem cell transplantation has already been covered by my co-instructor. So, and then the corneal transplantation. So the corneal transplantation is indicated in cases where there's corneal opacity, which is interfering with the which is causing visual impairment. So one can employ both the penetrating as well as the lamellar corneal transplantation. It is important in corneal transplantation that the ocular surface is quiet, there's minimal inflammation of the ocular surface, the IOP is controlled, you have prepared the bed properly, and then you can proceed with the corneal transplantation. So the indications are, when there's a stromal scar, there's advanced keratoconus or thinning, the non-resolving shield ulcer, there's perforation or an impending perforation. The important is that, as I said, there's so this is how one would want to proceed with a case of penetrating keratoplasty. In this patient, we did a trap with MMC also because there was secondary glaucoma in this patient. So we first did a trap followed by corneal transplantation. So the penetrating keratoplasty is done in similar way, just like you would want to do any other optical PK. The suturing is important here. You would want to bury all sutures because the children are while in the post-operative period, if they have any inflammation, if there's any foreign body sensation, they would rub and they would just dislodge. So it is important that the suturing is adequate and all the sutures, knots, everything is buried. The inflammation and the tissue damage should be minimum in these cases, and so the application of 4 cardinal sutures and the rest of the penetrating keratoplasty, it proceeds just like you would want to do in any other case. So, and then one video of the lamellar transplantation, and the video courtesy is Dr. Pratik Gurjar, who did this lamellar transplantation in a case of scarred keratoconus in VKC. And the procedure was the groove and peel technique. So with the help of blunt scissors, you can do a groove and peel technique, or any technique which is suitable in your hands. You can do the lamellar transplantation. So this is how we proceed with the groove and peel technique from the peripheral side towards the center, and removal of the cap gently from the surface and transplantation of the tissue. So we can tailor the techniques to the specific requirement of a specific indication, the specific disease severity for an optimal outcome. And post-operative management is as important as the pre-operative and the surgical intervention. So which one would want to continue with the post-operative drops, the immune suppressive or the anti-inflammatory drops, antihistaminic drops to take the inflammation to minimum. And so the key takeaways here is that the surgical intervention should always be done in minimal inflammation. The procedure should be pathology driven, and if there's structural damage, the steroid has to be, there has to be restraint in using steroids in all cases, because not all cases would require steroids. Counseling on chronicity is important. Thank you very much for your patient hearing.
Thank you for this amazing talk, ma'am. Wonderful videos and demonstration. Do we have any question here? Yeah, we'll have it later. So moving on to the next presentation, may I request Dr. Radhika Tandon ma'am to come and have a talk on pharmacological management of vernal keratoconjunctivitis, what works and what is next.
Hello, thank you, Dr. Bhavna, for involving me in the instruction course. Thank you for the audience. It's very encouraging to have people attending the session. Excuse me. So I'm going to talk about the pharmacological management of vernal keratoconjunctivitis. Dr. Bhavna made a very important point that even if you go for surgery, I'm sorry, I've got a bad throat. You must control the disease, and have a staged approach. Even when you're giving the medical therapy, you don't have to follow the steps from zero in each and every case, because the person has come in a severe stage. You don't have to start with the basic lubricants only. So you have to have your practical, logical thinking. And if the patient has come after seeing multiple other doctors, take a few minutes to organize the charts of whatever previous treatment they've had and ask the patient also, because otherwise they tell you, we've tried everything, but they may not have tried it in the proper dose and for the proper duration. So we know it's a chronic recurrent disease, predominantly affects children, more common in warm climates. It's literally considered like an epidemic in our country, and the pathogenesis involves IgE-mediated hypersensitivity inflammation. So you have to control the allergic inflammation, break the vicious cycle, provide symptomatic relief, prevent corneal complications, reduce recurrence, and most importantly, minimize steroid-related adverse effects. And you have to educate the parents as well as the child not to self-medicate with steroids. So preservative-free lubricants are your first-line therapy, supported by cold compresses. Now we use the word compress, but again you have to explain that you're not to compress the eye, it is more like a cold sponging. And we now know the importance of avoiding of touching or rubbing the eye and avoiding pressing on the eye. So sometimes they have a habit of very vigorously splashing water in their eye, or they're sleeping upside down, or they're sleeping with their hand pressing the eye. Or some of them have a habit of sucking the thumb and rubbing one eye. So these are things which also you need to check. And then you start dual action antihistaminic mast cell stabilizers. Olopatadine and bupotastine are some of the newer medications. I don't use much of ketotifen and azelastine, and they're best suited for mild VKC. Sodium chromoglycate, a lot of people still have a lot of faith in it. However, it's very slow to act. So I usually as a first line, again, I stopped using it, but some people still like to use it. And then lidoxamide nidochromil. Basically, the mechanism is to prevent mast cell degranulation, and these are safe for long-term use, but slower onset of action. Now coming to the importance of topical steroids. They're required for moderate to severe VKC, and they can be given in spurts. So don't leave an open-ended prescription. See, depending on the severity, start with 4 times. Never need to give 1 hourly, 2 hourly. This is not a disease where you have to give 1 hourly or 2 hourly. Maximum you may have to give 6 times, but usually 4 times is absolutely enough. And then you try to give it over a burst of 1, 2, 3 weeks, along with something else which is going to work eventually. I like fluoromethalone, but otherwise you can use loteprednol. More severe cases, you have to start with prednisolone and then switch to the milder surface acting or the softer steroids. Rapid suppression of inflammation and the risk of steroid glaucoma and posterior subcapsular cataract is very real. Then we have immunomodulatory therapy, which is steroid sparing. We have the calcineurin inhibitors, cyclosporin and tacrolimus, which suppress the T cell activation and cytokine release, and are useful for chronic and recurrent VKC. Now, in our practical experience, I find that tacrolimus has sort of replaced cyclosporin, because you don't have to put it in the eye, you can apply it on the lid. So, okay. It's a potent calcineurin inhibitor. It's available as 0.03% and 0.1% ointment. Reduces the symptoms and can be applied over the upper lid. This is a key. Can be given once or twice daily and then gradually taper after disease control. So if you do start it twice a day, you can shift to once a day in 1, 2, or 3 months. But more than 3 months, never give it twice a day. And reduce it to once a day. And usually give it for a maximum duration of 1 year. You don't have to give it for 1 year, but 6 months to a year, but don't give it for more than that. Common side effect can have transient burning or irritation and no risk of glaucoma or cataract. So VKC requires stepwise management. Antihistamines and mast cell stabilizers with lubricants are the first line, along with cold sponging and other behavioral advice. Corticosteroids are useful for acute exacerbations. Calcineurin inhibitors provide long-term control, and tacrolimus is an effective steroid-sparing therapy. I'll quickly give you a little support for why I say tacrolimus. The therapeutic effects have been shown to be useful for refractory ocular surface disease as long ago as 2008. That was a topical suspension. Later on, a randomized placebo-controlled clinical trial again showed that it is effective, but then again it was inside the eye. Very nice paper by from Bihar, from Patna RIO, in their, I think, Bihar journal, iQuest. Comparative evaluation of topical tacrolimus 0.1% and 0.03%. Do read the paper, it's available free online. And then the therapeutic effect of drops in the tarsal form. We have our own experience of dear tacrolimus levels and clinical response after adjunctive therapy with cutaneous application. And I'll say in a nutshell, start with once a day. Start with a lower concentration, 0.03%, because the Patna study did show that 0.1% has higher complications of burning, irritation, etc. So start with 0.03%, start with once a day. And you can prescribe it for 3 months and then up to 6 months. And that's it. Thank you.
Yes. Thank you, ma'am, for a very insightful lecture on all the aspects of medical management of VKC. Now, I invite my next co-instructor, Dr. Sunita Chaurasia. She's heading the cornea unit at LV Prasad, Hyderabad. She'll be speaking on inflamed and ectatic, the complex overlap of VKC and keratoconus.
Inflamed and ectatic, and I'll be dwelling upon the complex correlation and coexistence of VKC along with keratoconus. So there's a lot of commonality between VKC and keratoconus. If you look at the disease per se, the age of onset, the varied spectrum of the disease, course of the condition, etiology, treatment, all that is sort of similar in VKC and keratoconus, and both have a debilitating impact on young patients' social, psychological, and educational development. If you look at the pathogenesis also, as Madam has highlighted, there's sort of similarity between VKC and keratoconus. Both have inflammatory pathogenic basis. So the pathogenic components in VKC as a disease are toxic to the corneal epithelium, degrade the epithelial basement membrane and the stroma, thereby have a role in progression and the implication of the disease as keratoconus. Eye rubbing is an important risk factor, as we all know about keratoconus, because this damages the corneal surface both by mechanical trauma and the release of inflammatory substances. So there's a two-component theory of keratoconus. One is the inflammatory basis and then the mechanical component, and with the predisposing risk factor, which obviously happens to be the genetic predisposition. The secondary increased inflammatory activity, which is released as a consequence of eye rubbing, has further activation in the disease process, causes keratocyte apoptosis, leading to degradation of the stromal collagen and progression of keratoconus. So if you look into the prevalence of keratoconus amongst VKC patients also have giant papillae, and this further adds to the physical trauma component and secondary inflammation upon eye rubbing, intensifying the relationship between the two conditions. In various studies, it has been found that there's increased odds of keratoconus in VKC patients to the tune of 6 to 8 times in many of the studies. If we look into the prevalence studies, there's an association of keratoconus of 10% to 30% in some of the studies in VKC patients. Of course, if you look at the topography findings, 70% of the VKC group have an abnormal topography compared to 40% in the control group. So there's certainly a co-association between the two entities. So the coexistence of VKC and keratoconus has several implications because there are complexities in interpretation of progression of keratoconus, leave alone the diagnosis also sometimes, which can also be difficult in some of these instances because of varied morphology of the condition. Now, typically when we talk about keratoconus, the non-VKC spectrum, this involves inferior corneal steepening, and a superior steepening pattern, however, can exist when the disease is associated with VKC. The limbal lesions interfere with the interpretation and topography, and hence it is important to distinguish true progression of the disease versus a pseudo-progression. Let's look at some of the case scenarios. Now, if you see this patient who has giant papillae, has a shield ulcer, And once the disease heals, there's scarring. So obviously the scarring also causes certain bit of topographic alterations, and apart from the mechanical pressure effect from the giant papillae. If we look at these kind of cases where we have a very significant limbal form, these also will have impact on the corneal topography interpretation and findings. Many of these patients, because of inflammation, also have a thin cornea, need not always be keratoconus, but these are again spectrum where you have a severe limbal form of the disease, can also have thin cornea, but need not always be keratoconus. That apart, the progression of the disease becomes a little difficult when you have coexistence of limbal form with the keratoconus. So what is important is that when we see the disease in the early phase of the disease where there are minimal limbal lesions, it is important to do a baseline pentacam, which should be documented early to diagnose the condition per se. And sometimes it's important to have epithelial mapping on the anterior segment OCT to understand the progression of the disease in the future, to understand whether it's a real keratoconus or whether it is just thinning of the cornea. So these two things are important in the management of the disease and diagnosis per se when we see the disease in the early phase of the condition. Now, coexistence of VKC and keratoconus also has management consideration with respect to planning of the cross-linking, follow-up care after cross-linking, visual rehabilitation with contact lenses and keratoplasty, and addressing the various complications which can occur as a consequence of progression of the keratoconic disease. Now, efficacy of cross-linking and prerequisites which are required in the management, there are several things which we have to take care. The risk of disease progression and treatment failures are far more when the VKC and the keratoconus coexist, and it is important to have a good allergy control, both in the pre-CXL phase and post-CXL. Otherwise, doing CXL in an eye where the child keeps rubbing will eventually be a futile exercise, because quite often these cases tend to progress despite having a cross-linking procedure being done. Now, the other thing about the aspect of management for cross-linking in these patients is that allergy and coexistence of lid margin disease can also be a risk factor, and this co-association also puts them at risk of infections and sterile keratitis after CXL. So ensuring a good lid margin cleaning protocol prior to surgery is essential part of the management for these cases when planning for a cross-linking therapy. Now, visual rehabilitation with contact lenses. Now, when you send the patient for contact lenses trial, it is important to see that the disease is in the quiescent phase for an optimal tolerance of the contact lenses. Quite often, they don't tolerate the lenses. Lenses cause an impact on the limbal region, and they can have a contact lens intolerance. Apart from that, regular cleaning of the lenses is also important too, because these patients are prone to debris deposits in the contact lens per se. And this is just one case of showing a very severe deposit in contact lens user who had keratoconus and VKC, and quite often they become intolerant if this is not taken care right on time. Now, rehabilitation with keratoplasty has its own issues which we need to be very careful about and need to understand. Now, disease, when we are managing with keratoplasty as a visual rehabilitation, it's important to see that the disease is in the quiescent stage prior to keratoplasty. Now, the clinical quiescence need not always be related, is not similar to ocular immune quiescence, because what we see clinically may not be apparent at the cellular level. Quite often these eyes are inflamed eyes and they behave differently after keratoplasty. There are significant suture-related issues which can heighten in these patients because of an increased and exaggerated response state of the condition. Healing occurs far more rapidly in these patients because of the inflammation. There's a tendency towards suture loosening. And because of this reason, there could be suture-related infections, erosions in the graft per se. Shield ulcer can occur in the graft also because of uncontrolled disease or a flare-up of the condition. And these eyes are also prone for stromal rejection. This is how do we manage when we encounter this condition when along with the keratoplasty. Now, one of the important things is that when these patients undergo keratoplasty as a part of management, we have to have a close watch in the initial few months until a stable ocular surface is achieved. Quite often, tarsorrhaphy, frequent steroids, use of bandaged contact lenses for an extended period may be required, and the role of immunosuppressants. This is something which is very important part of management of some of the patients who undergo transplant for keratoconus in association with VKC. Many of these patients may also require amniotic membrane grafting with the BCL when they have an acute flare-up. Now let's look at some of the case scenarios. This was one patient who had a DALC for keratoconus with underlying VKC. Now we see that day 1 and 1 week the cornea looks very good, but over time at 2 months we start seeing suture loosening happening at the graft-toes junction. Now, particularly if you look at the graft-toes junction, there's so much of scarring seen in the site where the sutures are evident. This scarring is a phenomenon which is seen in these cases because of exaggerated healing response. Now, these have to be addressed on time, and that is very different from non-VKC cases where follow-up may be a little spaced apart, but these cases have to be followed up more frequently compared to other conditions. This is one more case who had hydrops in the past and the cornea is very thinned out. It's obvious that the disease is quite advanced because of extensive thinning. And this patient also had, he's an adult patient, but had a severe uncontrolled recalcitrant VKC, and he was not tolerant to the contact lenses. This kind of picture was very similar in both the eyes, and how do we manage? So this patient was managed with transplant, with a large graft. Again, this patient, the post-operative period happened as is anticipated in these conditions. They can have a shield ulcer in the graft itself, and this is what we had to deal with in the post-operative period. However, with the good oral steroids and immunosuppressants, this patient was brought under control and is doing well as of now. Now, stromal rejection again can be more common in these cases because again, these eyes have a baseline inflammation going on, so that has to be taken care. Having said that, the outcomes of graft in the burnt out stage of the disease where we have a situation like this one, this was a pediatric patient who had a long-standing disease, but the disease had got controlled but with the scarring. Now this patient underwent in both eyes DALC and has more than 5 years follow-up, is doing quite well. So the disease in the acute phase versus the disease in the chronic end-stage disease will behave differently and the outcomes will be far better. So this patient has a really great outcome and has several years of follow-up now. Now again, apart from the other management issues, now many of these patients because of chronic rubbing may also have occurrence of eye drops. Now this can significantly impact the vision if it occurs in the central visual axis with the scarring. Quite often because of inflammation, there may be fluid peripheral vascularization also which happens and then it makes the bed little hostile for the future keratoplasty. So avoiding eye rubbing, again, just like in other situations, it's important to make sure they don't rub their eyes. Now here I just want to highlight one point. Quite often when we see eye drops with a situation like this one, now in this case, if you see the anterior lamella has a sufficient stromal thickness. Now in these cases, we can manage with the compression sutures for an optimal recovery. But something like this where there's a very minimal anterior stroma, these kind of cases may not be ideally sutured with compression sutures because they land up with causing more scarring. This patient happened to have that, but this is not the indication for doing compression sutures compared to the other previous indication where there's a sufficient stroma. So this distinction is important because quite often we can't manage these patients with contact lenses. They have to be only managed with glasses. So this is an important part in management of eye drops in such a scenario. Sometimes the eye drops can also be superadded with infection, and this is something to look out for when we are seeing these patients. So in conclusion, concomitant VKC with keratoconus requires a more aggressive treatment and rigorous follow-up in management. Immunosuppressants have a key role in reducing the morbidity and ocular complications, and keratoplasty post-op care needs a more focused and close follow-up for an optimal outcome. Thank you.
Thank you, ma'am, for a very insightful lecture. And we have our last presentation by Dr. Nikhil Gokhale, who will be speaking on severe VKC's approach and experience, a case-based discussion.
कनेक्ट करना है क्या? For giving me the opportunity to be here today. What I would be basically doing is that there is a little difference in the topic that was communicated. So anyway, basically I would be so I would be speaking on how we would do a step-by-step management of VKC and how do we practically use an algorithm which is based on disease severity. So it sort of goes through a lot of information which you've already gone through. So I think we understand that the allergic eye disease is one of the most important surface problem next to dry eye, and in our country we have forms right from mild to blinding disease, and we are seeing increasingly more patients who have chronic disease, severe disease, early onset disease, and because of self-medication we also see a lot of more complications than others in practice. To reduce a lot of complications and morbidity due to allergic eye disease, we need to have a systematic approach to managing these conditions. And of these 10 steps, basically I'll try to highlight how do we grade the disease and how do we manage them in a stepwise fashion today. So you saw this classification a little earlier in the first talk. Basically what I would like to highlight is that we need to understand at each point of time when the patient comes to us in clinic as to what we are treating, how severe it is, and what is the sort of disease we are treating. So as was discussed earlier, one could have patients who have few episodes, maybe 2 or 3 or 4 episodes in a year, and they are pretty okay in between. And then we can have a subset of patients who have a chronic disease which goes on and on without much periods of remission. We could have mild disease, by which we mean there is no corneal involvement. We could have moderate disease where there is early corneal involvement. We could have more severe forms of corneal involvement in patients with severe disease. And then we have some patients who come to us with recurrent shield ulcers, chronic limbal inflammation, which tends to threaten the limbal integrity. So these are patients where we know that there will be corneal scarring, limbal deficiency, and we might end up in losing vision and might require surgical intervention. So these are the blinding forms of allergy which need to be aggressively managed. An additional set of patients are patients who already have complications by the time they land to you. So they might be already having scarring, LSCD, cataract, glaucoma, keratoconus, or a dry eye. So when these patients come to us in clinic and they have an ongoing active allergy at the same time, we would label it as a plus disease, because again these would require a little bit more aggressive management than the conventional management approaches that we use. However, there will be some where the disease has burnt out and now they come to us with a inactive allergy, but signs because of chronic previous allergy which was probably not managed adequately, and then we have to treat these patients as a minus disease, I would call it, and then treat them a little differently because they need different interventions. Unfortunately, when a patient walks into most of our clinics, they have undergone the 4-3-2-1 steroid protocol several times before they come to you, and it's often difficult to figure out what the patient exactly has, what is the severity of disease, periodicity of disease, what is the duration of disease. And sometimes when they come to you, they're already on some medication which is sort of suppressing the signs that you see in the patient, and you don't know how really bad it is. So I think we need to spend some time with the patient and the parents and discuss and look at all the previous treatments and what has been the response to treatment. So somebody who's used surface steroids and has had a complete response or a complete remission in the eye, they said looks good after treatment, but it again comes back very quickly on stopping the drops, possibly maybe having a more chronic form of VKC, whereas somebody where they have a remission lasting for a few months might be having an intermittent variety of VKC. However, if with surface steroids the response has been only partial, possibly you're dealing with more severe forms of a chronic VKC in these patients. And then you could have patients who have used potent steroids, and with potent steroids, if they had again a remission which lasted a very long period of time, this might be an intermittent form of VKC, whereas if the recurrence was pretty quick, this is possibly a chronic VKC of a moderate to severe grade. And there will be some patients who will say that despite use of potent steroids, they did not have any adequate response or a partial response, and these are patients where we understand the VKC would be much more severe, and possibly some of them may have a refractory forms of VKC. And patients who did not have any response to therapy might again be those where the disease is either severe or they are refractory to treatment. So before we plan what we need to do, we need to understand and counsel the patients, because usually the parents would be extremely anxious. It's a non-resolving problem. We need to talk and discuss with them what we are trying to do. We are trying to achieve control and not cure the disease. And the objective of our treatment is to reduce tissue damage, minimize side effect, use a stepladder pattern to target inflammation, discuss the safety profile of our treatment, and I think what's most important is to have compliance and good follow-up. So all these things need to be done on day one so that we would be better off in handling these complex situations. Also, we must treat based on what we see more than what we hear, because that disconnect is not unusual in patients with VKC. So basically all forms of VKC will require use of lubricants, antihistaminics, dual acting agents, and so on. Patients who have episodes maybe 2 or 3 times a year, we are fairly okay using a soft steroid in pulse therapy for these patients, and they would be pretty okay. However, when it comes to chronic disease, I think we need to use calcineurin inhibitors typically to try and use them as a steroid sparing agent so that we do not require or we minimize the use of steroids. So patients who have chronic disease which is moderately severe, one would like to use either cyclosporin or tacrolimus. Please see that the cyclosporin is 10 times more than the commercial 0.05% as I mentioned here. And in patients with more severe and blinding disease, you will use higher concentrations of these calcineurin inhibitors. You will have to use potent steroids, supratarsal steroids, and the most extreme varieties you might need to use systemic immunosuppression. Patients with plus disease will need surgical interventions often for the complications they've come to you with, in addition to managing the allergy, and patients with minus disease will require more of surface reconstruction, scleral lenses, and sometimes keratoplasty. In general, the acute phase could be managed well with steroids, preferably soft steroids if they work. However, in the chronic phase, always use steroid-sparing agents and dual-acting agents as a long-term management plan. So this is the same information put into another way in a different form of a chart, just to highlight that the mild allergies don't need steroid, intermittent allergies can be treated with soft steroids, moderate, chronic and severe and blinding varieties need calcineurin inhibitors at higher concentrations and sometimes systemic treatment. The objective of the step ladder is that whenever the patient lands up in our clinic for follow-up, if the disease, based on the grade of disease, you can go up or down the ladder so that you are giving them optimal therapy. And you want to avoid over or under medication and ensure that the patient does not develop complications. Cyclosporin drops, as I mentioned, need to be prepared in the clinic because they cannot be, the commercial available cyclosporin might be effective only for the extremely mild forms of VKC and is typically ineffective for the moderate to severe forms of VKC. So one could use injection and prepare it, or one could dilute the orosporin 2%, which is fairly not tolerated by most patients at that concentration. And basically it can be used on a long-term basis, unlike the 4321 needs to be used on a long-term basis because the disease is not going to go away, and it's fairly safe because it does not have the complications of steroids. Now we have also tacrolimus, which can also be used in patients who cannot come to get the refill of drops which are made in the clinic. However, tolerance is one of the issue with cyclosporin. I think shield ulcer management has been already discussed. Very important to rule out infection in any patient of shield ulcer, because the treatment of shield ulcer is steroid and you don't want to use it if there is still an active infection or a secondary infection. Systemic immunosuppression is often required in these patients in the extreme forms of VKC, as I mentioned, and in these, for the short term, oral steroids will do well. However, when you look at the long-term management, one would have to use cyclosporin, tacrolimus, and in occasional patients with an extremely high IgE level with systemic allergies in multiple organs, one would like maybe to try omalizumab. There are also some recent evidence of use of JAK inhibitors for this indication. So they are basically required pretty rarely if you manage them well. However, steroids may be required in an emergency management of inflammation in a severe VKC, and cyclosporin may be required either for chronic disease management in severe VKC or in patients who undergo reconstructive surface surgeries. And it can be sight-saving, and it can really prevent blindness. It can prevent patients going into scarring and limbal deficiency, which subsequently again needs a surface reconstruction with again systemic immunosuppression now for a very long period of time. And I think we all need to understand our limitations. We individually may not be able to treat most of these patients who are severe, and take the help of several other specialists, including the tertiary eye care centers, so that we can effectively manage them in a better way. And I think when you discuss allergy management, the three most important pillars are the patient, the eye surgeon, and the parents, and we need to all interact well to have a successful outcome. Thank you.
Thank you, sir, for very important points on management of VKC, both the severe and the mild cases. And I think that concludes our session on VKC, and we are hopeful that the session was fruitful for you all on managing various modalities and technical tips for management of VKC. Thank you very much.